Good evening, everyone. Welcome to Burjeel Hospital, Dubai and Orthopedics 101. This is the second episode in the series. So this is the series where we tackle orthopedic conditions both in children and in adults, but more from a family's point of view rather than a doctor's point of view. My name's Gavin Spence. I'm a pediatric orthopedic surgeon, so I just deal with children. And today's subject is cerebral palsy, which is a really fascinating topic, so much to talk about. And here to talk about it with me, I'm really honoured to have a fantastic guest, Dr. Arif Khan, consultant neurologist at the Neuropedia clinic, amongst other appointments. Arif, you're very welcome. Thank you so much for coming.
Thank you so much for the opportunity, Gavin. And I think that this is the first of its kind that we're having something like this, where an pediatric orthopedic doctor is inviting a pediatric neurologist to talk about a topic which is so important for parents to get a grip on and provide the appropriate therapy for their child. So I'll just tell a little bit about myself.
Please.
So some of you might know what I do and who I am. So my name is Dr. Arif. I'm a pediatric neurology consultant, and I'm the founder and CEO for a neuroscience center called Neuropedia, and that's the first children's neuroscience center in the country. And we started 3 years ago. We're based in Jumeirah, and we only look after children, as Gavin does. But we have a very wide holistic team, which includes physiotherapists, speech therapists, and occupational therapists. We also focus on autism. We've got behavioral therapists and behavioral analysts, psychologists, psychiatrists, neurologists, and basically the entire, all the components of neuroscience for children, short of neurosurgery. And we collaborate very closely with Dr. Gavin and his team out here in Burjeel, sharing patients, sharing opinions, and from which we've had great feedback from patients and their families. And I think sessions like this would go a long way in establishing this relationship even further and passing that awareness and knowledge on to parents who need them on a regular basis.
Sure.
So, Gavin.
Thanks, Arif. Yeah, so I mean, the communication is really important. I think we'll get onto that a little bit later on. But so cerebral palsy, shall we start with the basics?
We should, yes.
So you're the man to answer this question. What is cerebral palsy and what causes it?
Yes, I think that's what we need to start with, is cerebral palsy, the definition. And I'll just take a little time to explain the subtleties of this. Cerebral palsy is not a single condition. And that's the kind of misunderstanding that many, not only parents, but even clinicians have. Cerebral palsy is a group of conditions, and it's more a descriptive condition rather than being a single diagnosis. And it is a non-progressive neurological disorder that causes mainly motor, which is the ability to move as such, a problem with that, along with posture and balance. But beyond that, even, children might have other comorbidities like epilepsy, speech difficulties, problems with vision, problems with hearing, problems with their spine, in fact, and everything else that goes with it. So a child who has cerebral palsy doesn't have one single condition. The reason why a child is having cerebral palsy could be multiple. And that needs to be looked at as to why the child has developed cerebral palsy or CP, rather than trying to find out, does the child have cerebral palsy or not? And we'll talk about this as we go along, Gavin, yeah.
Sure. So it's a very varied condition, isn't it, cerebral palsy? I think that's the other point. There's a spectrum here, certainly in terms of children's abilities and functions.
Yes.
So can you tell us a little bit about the different types of cerebral palsy? There's ways of classifying these types, but
yes.
I don't know how useful these classifications are.
Yeah, I think there are two major types of classification. The first is depending on which part of the body is involved. So you can have monoplegic, which is one of the limbs, which is your lower limb or upper limb might be affected. It could be diplegic, which is both lower limbs having difficulties, usually seen in premature babies. We call that as spastic diplegia. Or it could be hemiplegic, usually seen with strokes, for example, in children. Either the stroke could have occurred antenatally, that is before birth, during birth, or after birth, but it leads usually to a half of your body being weak. So monoplegic, diplegic, even quadriplegic, usually in term babies, they tend to have quadriplegic cerebral palsy, where all four limbs are affected and your central core is weak. Now that's based on the topography or which part of the body is involved. There's also on the type of the movement problem. For example, you might have the most common ones in 80% of children is spastic cerebral palsy. That means your muscles are stiff. And again, I'm sure Dr. Gavin will talk about that. The other two are the ataxic one, which is pretty rare, in which you lose your balance very often, but the tone is not a big issue. You might have a little low tone. And the other one is dyskinetic. That means you have extra movements on top of your tone issues, what we call as chorioathetoid cerebral palsy. So to keep it simple, the two common ones are spastic diplegia, which is seen in premature babies, and spastic quadriplegia, which is all four limbs involvement in term babies.
Is it true that this is becoming a more common condition, cerebral palsy? I'm sure I read that somewhere.
Yes, you're right. I mean, even though people would say, oh, medical science is advancing so fast and still we are having more cerebral palsy, the basic reason for this is we are saving a lot of premature babies. And because we're saving a lot of premature babies, the viability has gone down to even 23 weeks now. So we have so many 24 weekers, 26 weekers who are surviving with good quality of life. And of course, the price we have to pay for that is children with some form of neurological deficit who need a lot of help.
Sure. So this is the sort of spectrum of conditions, and you've explained a little bit about how those arise. But can you tell, I mean, you hinted a little bit about comorbidities, but how does this condition affect children? You've mentioned a few sort of general areas.
Yes.
Can you give us a few more specifics?
Yeah. So beyond the movement, which is the key here, which is either child not able to walk at the time when the child's supposed to walk, not able to sit at usual 6 or 7 months. These are the physical issues that we come across. I'm sure we're going to talk about that.
Yeah, sure.
They will have issues like speech delay. They might need help from speech therapist, or they might present with visual problems, and they might need some stimulatory help from a visual occupational therapist. They might have difficulties with epilepsy, and many of them do have epilepsy problems, and the seizures need to be controlled. They might have problems with swallowing as such because the neck muscles are weak, and that needs help. They might need some different forms of feeding, like a PEG feeding or a NG tube feeding. So because of the main issue with the brain, many systems of the body are affected. And that's the reason we need a number of experts or physicians or professionals dealing with the child, keeping the child at the center. And again, we'll be talking about that at the end, probably.
Sure, sure. So in terms of treatment, I mean, I'm a surgeon. I left treating with medical therapies a long time ago, but that's very much your area of expertise. So can you tell us a little bit about what sort of medical therapies, what sort of medical interventions you can use to help these kids?
Yeah. So because the physical or motor problem or movement problem is the key with cerebral palsy, what comes to your attention, children bring in these children saying he's not meeting his or her milestones. He's not able to walk when he's 18 months, or he's not able to sit when the child is 8 or 9 months. And the first thing we do is we try to find out the reason why this has happened. So we investigate. Might need an MRI scan, the child might need certain other tests. And then we involve the team, including physiotherapists, to come in and start working with the child's tone, for example. We involve the ophthalmologist, we involve the swallowing specialist, and we give a holistic kind of approach to the child. Usually the pediatrician or the neurologist takes the central role and tries to coordinate all this. And when we decide, okay, now we put the child on some medications to relax the tone a little bit. I'm sure you would have heard of things like baclofen or diazepam. But it helps us to a certain extent for physiotherapists to do their work. Sometimes we give botulinum toxin to relax the muscle, which helps the physiotherapist, again, to relax the tone and help the child improve their posture. And at times, many of these children need intervention from orthopedic surgeons in terms of various procedures that they might benefit from. And that's when I refer to Dr. Gavin to help us out with that.
Sure.
So, yeah.
Okay, great. Thanks.
Great. So I think moving on from here, we talk about how we treat medically, and at times we have to then knock on the door of the orthopedic surgeon and say, I'm not able to manage this child. The child has had 6 months of physiotherapy. We've given botulinum toxin. The child is not walking, is walking on tiptoes, and I need your opinion.
Sure.
So, and the patient comes on to you, Dr. Gavin, from me. And how can you help these children who, in their walking, basically, if we take that as a milestone?
Sure. So walking problems in cerebral palsy, I think, are more complicated than they might at first appear. You and I, you don't think twice about it. We just get up and we walk. It's a fluid thing. We forget that it took you 7 years to learn how to do that. Walking is a process which is highly tuned and highly complicated, particularly in species like ours, which have decided to walk on 2 legs. So all of those muscles in your legs, and you'll remember from your anatomy school, I hope you remember,
Yeah.
there's lots of
A
them,
little
right?
bit.
And they're all firing at different points when you take a step and then when you move forward. So that kind of control takes a long time to develop. And one of the main problems that children with cerebral palsy have, and it's often the first thing the parents notice, is that they're not able to get the pattern, get the motor program. The software is not working to get the hardware together. So that's the first challenge. The second challenge is about abnormalities of tone. I mean, you mentioned spasticity. So I know there's whole conferences defining what spasticity is, but I mean, to us, it means that when you try and move joints, there's often resistance to that, without going into the details of it. So that's often the second things that parents notice. So we've now got these two issues going on. And as an orthopedic surgeon, there's a limit to what I'm going to be able to do about those kind of things. So the reason I mention this is just to try and paint a picture here of how complicated these problems are and on how many fronts these kids have problems that need to be addressed. And orthopedic surgery is just one aspect of it. But where we really come into our own is more on the long-term effects of cerebral palsy on growth. So there's nothing wrong with these children's bones. They're growing just fine. But those kind of abnormalities of muscle tone and muscle control that we've talked about, they seem to affect muscle growth. So you can imagine if your bone is growing, but your muscles are not, then sooner or later your joint is going to have to accommodate this by moving and adopting a sort of contracted position. So the classic one would be the tiptoe walking that you just mentioned. So that's the first stage, I suppose, at which we often get involved with the development of contracture. Again, left to its own devices, those contractures can have secondary effects on the growth of bones. So they can become twisted or deformed themselves, and depending on the type of cerebral palsy, we can actually see quite serious problems with hips, which we might get onto later. Yeah. So those are kind of pretty complicated issues to face, and we orthopedic surgeons, when we're dealing with those kind of gait problems, have to keep all of that in mind, that we have actually relatively blunt tools in the toolbox, but we do have some tools. So orthopedic surgery can help. And this is an important point, right? Because orthopedic surgeons traditionally and still today have a somewhat checkered reputation when it comes to treating children with cerebral palsy. And the reason is this, that in days gone by, let's say sort of 30 years ago, it seemed very clear to orthopedic surgeons, the muscles are tight, the tendons are short, how hard can it be? Do an operation, make the tendons longer, job is done, right? It turns out things are a bit more complicated than that. So if you think of a muscle like your calf muscle, you would have been taught in your anatomy lecture theatre that is a muscle which is a flexor. So it brings the foot down and pulls the heel up. And that would be true if you're just looking at it in isolation. Actually, what these muscles spend most of their time doing is putting the brakes on. So they're not so much contracting and pulling, they're sort of more paying out the rope and stopping you from collapsing. It's a slightly more complicated way of thinking about it. So failure to understand that 30, 40 years ago led to some pretty poor results from orthopedic surgery. Not in all cases. Some kids did well, some kids did pretty badly. And I think generally the medical fraternity shrugged their shoulders and said, well, that's cerebral palsy, very hard to predict. But I think the game really changed in the 1980s, certainly into the 1990s, when we began to look more scientifically about how children walk. And gait analysis in particular really gave us an insight into how complicated these problems are. And we've begun to understand now how we need to refine our surgery. And look at it this way. A child walking with cerebral palsy may not be walking normally as you or I would understand it. But sometimes they're walking abnormally because they have a compensation. They're employing a compensation to be more efficient. If we do an operation and take away that compensation, you have not done any favours. On the other hand, if they're walking in an abnormal way because there is an obstacle and you remove that obstacle, then you've helped.
You're talking about functionality here, isn't it? I mean, many people oversee that and then realize, oh, we've actually made this child walk, who was walking very well, with some slightly abnormal gait, is not able to walk anymore.
Sure.
So that shouldn't happen, isn't it? Just like that.
100%.
Yeah.
And again, we as orthopedic surgeons, we deal with the surgical side, but then we need help from physiotherapists, particularly for the whole rehabilitation process. So it's not just a question of the operation fixes it. We're often actually creating a bit of a mountain for that child to then climb, which is where the collaboration and the teamwork and the understanding, the agreeing goals is so important, because we have to be careful that we don't do so much surgery that this mountain is now too much, and the child just gives up and says, you know what, this is just too hard. But so that's I'm talking there about ambulant kids who can walk. Not all kids can do that.
So I'll if that is ambulant kids, if I'm seeing a child who's able to walk with tiptoeing or with slightly stiff legs, I would refer to you. Then there are some options for the child. Now just imagine I see a child who's, say, 3 years of age and is not walking, and maybe is just moving from one place to another within their living room by just crawling. And this child has spasticity and has, say, quadriplegia, and we think about improving the quality of life for this child, not just mobility, but quality of life as well. And I'm sending this child to you to see what Dr. Gavin can do that will improve this child's quality of life. So do you want to just say a few words about that?
That's a common scenario, and you know, I think it's all about setting the right functional goals for a child like this and being realistic. So one of the things that I would sometimes discuss with families, there is often a lot of pressure, particularly on a young child like that walking must happen. We must get walking. Well, for some children that's not realistic. And if you look at adults with cerebral palsy, walking it's an important function, but it's not crucial. You can function in society normally without the ability to walk. So what adults with cerebral palsy really crave is social interaction and communication. If you ask them, they don't put walking high up on their list. And that is something that I try and explain to parents when we think we have a child who we predict actually walking is not going to be a realistic option for them. So that's the first thing. We have to sort of be realistic. Else we're setting ourselves up to fail. Everybody's disappointed. You know, the physio's failed, surgery's failed, everybody's failed, when actually we're talking about the natural history of the condition. So function is really important.
I come across in my clinic children with cerebral palsy, especially, you know, if they have quadriplegia, for example. The main issue with them is, or many of them, is pain.
Right.
They are in discomfort, and that obviously affects their quality of life. Do you want to just say a few words on how surgery or any kind of intervention might help these children?
For quadriplegia?
For quadriplegic cerebral palsy, where pain is an issue, they're not able to sleep because of increased spasticity. We've tried a number of medications for them. And then how can orthopedic surgery help in these cases?
So obviously when a child presents in that sort of situation with pain, we need to make a diagnosis. So quadriplegic kids, so these are kids with all four limbs involved. Very few of those kids actually manage to walk at all. So they're going to be largely wheelchair users. What that means is that we need to get a diagnosis really for what this pain is arising from. So there can be many causes. You know, they might not be orthopedic. The one we really worry about is hip displacement. So we know that kids with cerebral palsy are at risk of the ball slowly coming out of the socket. And that can be a cause of pain, but there could be others. You know, reflux is very common, and particularly when kids are sleeping, that could be the cause. So,
but that we as physicians would look into that. So whether it's reflux, whether it's sleep-related issue, and then I would say we've looked at all the medical causes of pain. There could be a displaced hip, or there could be severe spasticity, or some kind of a fracture that is being missed. And that's when we refer to orthopedic, isn't it, team?
And that's what we look for. Sometimes it can be a physical problem. It could be a deformity of some kind. It could be a problem that can be addressed with orthopedic surgery for positioning to be easier.
But we see this a lot of time when there's some disagreement between clinicians, isn't it? Parents come to us thinking, okay, we are going to get a similar opinion from everybody. That's usually not the case in medicine, as you would know, and many of the parents would know. So I might suggest, okay, this child might benefit from botulinum toxin injection, for example, in the lower limbs. But then the child comes to you with parents and you decide, I don't think so, botulinum toxin is going to help this patient. That's just an example. But when parents are faced with this kind of difference of opinion between two clinicians, how do you think we can kind of merge that together? I mean, I'm sure MDT or multidisciplinary team meeting is the key.
It is.
But can you just emphasize on that a little bit more?
I mean, it's absolutely crucial, isn't it? And sometimes MDT working, multidisciplinary, it trips off your tongue as being something that that is, it's politically correct to say.
Yeah.
I have to say, particularly for complex kids and particularly with kids with cerebral palsy, it is essential that we are all singing from the same hymn sheet. And yeah, I accept there will be different ways of doing things. There are differences of opinion, different approaches that might actually be successful.
Yeah.
But what is important from our point of view and what's important from a family's point of view is that we are all pulling together with the same goals. And it's all about communication. And you've been working here in Dubai longer than I have. That can be a difficult thing to achieve. I think it's still a little embryonic in this part of the world. Right?
And I would like to say this to the audience as well, that I'm not sure whether any one of you, as parents who have a child with cerebral palsy, have attended a clinic where you had 3 or 4 professionals sitting with you, with your child, and discussing the case with you. For example, a neurologist, an orthopedic surgeon, a physiotherapist, an occupational therapist, sitting together and talking about your child at the same time. That's very unlikely, at least in UAE, to happen. Mm-hmm. And what we are trying to do, along with Neuropedia, collaborating with Burjeel, is trying to at least come close to that kind of interdisciplinary and multidisciplinary care for children. So this brings us on to the next question then. If we are going to arrange something like this, like a multidisciplinary team approach towards these children, how would you take the first step, Gavin, for this? And how would it benefit for children in UAE as such?
Yeah, sure. I mean, I don't know. That's more a question about your approach in building services generally.
Yeah.
I mean, my approach has been to just go out there, meet people like you.
Yeah.
I met you earlier on in my time here.
Yeah.
Go and introduce myself, and I've actually found people are very keen to collaborate. Because I think everybody in their silos actually feel quite vulnerable, right? We need each other to...
Yes, absolutely.
These are complicated conditions. Let's not pretend that cerebral palsy is an easy condition to treat and you just need to find the right person who's got the answer. It isn't like that. We all struggle with it, right?
Yeah.
So it's about finding the right team on a personal level. And I think my approach has been to try and make those collaborations on an individual level and then grow it from there rather than to try and get it oven ready.
Absolutely.
To use
and I would tell parents, like I have a number of parents that come to me and they come with this notion that we'll go to Dr. Arif and he's going to make my child walk. I cannot make your child walk by myself. Even if I do, it'll be me with my physiotherapist, with Dr. Gavin being an orthopedic surgeon, the entire team working together. So, and the earlier we start the therapy, the earlier we start the intervention, the better outcome your child is going to have. So this is the strong kind of message to take home for many parents who are watching today, is that don't just wait. Try and get to the right person at the right time, especially as early as possible. And then with the help of that neurologist or that orthopedic surgeon, you probably will get into a team where many people are joining together and looking after your child and talking to each other. I think that's the key, isn't it, Dr. Gavin? It's not about me telling you what your child needs or Dr. Gavin telling you what your child needs. It's me talking to Dr. Gavin and saying, what do you think about this particular approach rather than the approach that you suggested?
Yeah.
So we can have a dialogue between us and then come to a conclusion and then discuss that with you. So you have a single opinion rather than multiple opinions from people who are not talking to each other. And that's the reason a collaboration like this would be so fruitful for not just us in our clinical practice, but many children out there.
Yeah. I mean, that's no more than clinicians have been doing for centuries anyway, really, I think.
But it's not, we aren't inventing anything. We're just trying to make it possible in this part of the world. It's very difficult because there are many issues like insurances, time. You're a busy clinician, I am. We work in 2 different organizations. And to bring that together, it's very difficult. And that's the key, isn't it, for us to develop something like that?
Yeah, it is. I mean, the difficulties are practical, but they're not insurmountable.
No.
Do you know one of the funny things that, there aren't many good things that have come out of COVID-19, but one of them is we're all very familiar with Zoom now.
Yeah.
So we had a patient recently who came to see us, I think also came to see you guys. And we sent him off for gait analysis. Right. So gait analysis, I think I mentioned it, didn't I? It's a very scientific way, because for his particular problem, we really needed to drill into the detail of what his walking problem was. And that then took place at a 3rd institution. There's now 3 of us. But actually, with Zoom, from our own homes, we were able to share that data, discuss it, come out with a report, without physically being in the same room. So it is possible to do it, but the will needs to be there.
Yeah.
But I think the will is definitely there from all the people that I've approached. I think we all feel the pain a little bit in trying to manage these conditions.
Yeah. And I think what we want to do is trying to reduce the travel time for parents and families going from one specialist to another, and that's the thing in Dubai, and that was the premise on which Neuropedia was made, where I had parents coming to me as a neurologist, going to a physiotherapist in a different organization, then seeing a speech therapist in a third organization, and they just get lost with that. So being in a single center like Neuropedia, they can all kind of receive those services under one roof, and we talk to each other. Of course, we don't have an orthopedic surgeon at Neuropedia, and that's the reason we are collaborating with Dr. Gavin. But whether it's virtual or it's direct, there has to be that dialogue between us, with the child in the center of this entire picture, isn't it? Yeah.
I was speaking to somebody today who made exactly this point, that in Dubai, if you wanted to go to a speech therapist, an occupational therapist, an orthotist, and a neurologist, you're driving around, you've got to park your car everywhere, you might have a kid with limited mobility. It's really difficult to organise that. Yeah. So that's what you've tried to do. Yeah. What were the challenges, though, when you set up Neuropedia? I mean, it's a great idea on paper, but did it just pick up like that, or? I mean,
keeping the challenges of developing something like that physically, keeping that away, I think the first bit was trying to bring people together with a similar set, kind of not similar but different set of skills. So getting the right physiotherapist, and my experience helped because I had worked with a few physiotherapists over 2 years that I've been here from 2015 onwards, and bringing them in, getting the right neurologist, the right technicians on board, the right behavioral therapist, and making a team. And because it's never been done before in terms of having the specialists under one roof, we needed to make protocols, guidelines, and policies that actually bind us together and that help a child. So that I think that was the key. The governmental licensing and building it as a business, that was not an issue. That had clear infrastructure, especially in UAE, it was pretty straightforward. But making the clinical framework for specific conditions like cerebral palsy or epilepsy, that was the key, because we had to do it from scratch for this part of the world. Obviously, in the NHS or in the UK, there are set guidelines that are nationally followed. Obviously, over here, many a times we don't have that, so we have to create that from scratch.
Yeah, sure. Yeah. So when the patients come and you think about referring them on to Burjeel or for an orthopedic opinion, do you what sort of questions do parents ask you about that? I'm curious, because when they always come very well primed to me.
Yeah.
So I'm just wondering what you tell them about what to expect, because
few times
seem to know.
I understand. We try to give as much information and the specific reason to them as to why I'm referring to an orthopedic surgeon. Simply, a child with tight Achilles, tiptoe walking, I just want to know from Dr. Gavin or the orthopedic surgeon, would lengthening of the tendon help this child? Yes or no? And if it does, then can the surgery be done for this child, and that will improve the quality of life? Yes or no? And that's the answer I need from you, and I tell that to parents. I want Dr. Gavin to let me know if this is possible. Yes, the child might be 10 years old and has not seen an orthopedic surgeon, and she should have seen 7 years ago. And that happens so often. And sometimes I might get an answer, no, the child has developed contractures, it's not possible. Or yes, it is possible, it's going to help the child a lot. So it all depends on it. But I speak to you, I send a referral letter to you saying, this is what I'm looking for, can you help us with this?
Sure.
And many a times parents take that and they move. At times it happens that I don't know what to do with this child's problem. Pain, for example. We've looked at all different aspects of why this child might be in pain. And then I'm lost, and I'm thinking, has this child has suffered a fracture, or the hip is dislocated? Obviously, that's beyond my expertise, and that's when I send it to Dr. Gavin and say, I don't know why this pain is happening in this child. Can you look into your orthopedic side, do all the X-rays, and let me know?
Sure.
A different question. So the question is very important as to why you're referring to an expert who has the expertise in that particular area that you're looking for.
Sure. So we're coming to the end of our time now. I just want to ask one last thing, which is about the future. Where do you think the big advances are going to be in treating these kids? Because we're using operations that frankly have been around for centuries. What we're just getting a bit smarter about the decision to use them. So that side has sort of changed really how we've done our practice. How about you, on the medical side?
Yeah, so new medications in terms of, for example, muscle relaxants that we use, or the medications we use to reduce the tone of the child overall. That is changing with time. So, for example, we never used to have things like trifenhexidil for tone problems or movement problems, tizanidine. There are new medications coming in and we're utilizing it. Same thing, newer anti-epileptic medications are coming, which are helping children control their seizures better. So not just the physical tone or movement, but also the comorbidities that we talked about. So with the advancements in the medical field, with the new medications coming in, the better understanding that we are having of this condition, we are able to manage them better. But one question that I would like to ask you is, if you break down the last 20 years in a kind of a 5-year block, do you think the number of surgeries you're doing for children with cerebral palsy has increased or has it reduced?
Oh, it's definitely increased. Clever about what we can do in terms of ambulant children. But the other big game changer is this idea about hip dislocation, which I mentioned. So there is a feeling in the orthopedic community now that hip dislocation is a preventable condition. So we are, previously where we did a lot of surgery to reconstruct a hip that had dislocated, and boy, that is a difficult job. We're now doing more limited surgery to prevent
So preventative rather than curative.
Yeah, so the focus has changed.
Yeah.
Dr. Arif, we're running out of time. I could talk to you all night about this because it's a fascinating topic and a topic very close to my heart, and I think to yours too. But I'd just like to really thank you so much for giving us your time and your expertise tonight.
Thank you for having me today, and it's a great session. And I hope the audience has enjoyed it as well.
So. Yep.
And hopefully we might have a few of these coming our way in the future as well, Gavin.
Definitely.
Probably you can pop into Neuropedia sometimes and we can have a chat about a slightly different topic.
That'll be fantastic. I look forward to it. Hope you've all enjoyed it. Tuning in on Facebook Live. Thanks so much for joining us, and please join us again for the next episode in Orthopedics 101. Thanks so much.
Bye-bye.